This is episode 99 of the Psychcast by MD Edge, where we bring you interviews with leaders in the field of psychiatry and psychology, masterclass lectures, and relevant inspiration, straight to your ears with new episodes dropping each and every Wednesday. I'm the voice of MD Edge Podcasts, Nick Andrews. Our guest this week comes from the 2019 annual meeting of the Group for the Advancement of Psychiatry, that's GAP 2019. Our guest is Dr. Frank Yeomans. Dr. Yeomans will be speaking today about personality disorders. Remember, each episode comes with robust show notes that include an outline to the topics mentioned in the show, as well as relevant links. Okay, so let's get right into it. Please welcome Dr. Lorenzo Norris and Dr. Frank Yeomans.
This is Dr. Lorenzo Norris, Editor-in-Chief of MD Edge Psychiatry. We are pleased to have Dr. Yeomans on the Psychcast today to talk about personality disorders and to really maybe give us some new perspectives or some additional perspectives on personality disorders and how we can continue to evolve and refine our thoughts across about personality disorders. Dr. Yeomans, welcome to the Psychcast.
Well, thank you. To begin to talk about personality disorders, I'd just like to mention that in the DSM system, they were relegated to Axis 2 for a long time, which in many psychiatrists' minds suggested they were kind of a lesser order of importance. And I think it's perhaps proper to think of them much more seriously within the context of psychiatry, because these are disorders that affect the whole person. Axis 1 disorders, as they were known, are more symptom-based. Personality disorders have to do with the whole experience that the person has going through their life, dealing with others, dealing with the challenges of life. So I think if we want to keep psychiatry a biopsychosocial area of medicine, we have to not focus exclusively on the symptom, but we have to think about the person who is experiencing the symptom and what their personality brings to their experience of their psychiatric problems, and to treat the whole package. Putting it somewhat differently, let's look at some research. There's a lot of research that's been done about people who have dual diagnoses. If you take somebody who has bipolar disorder and borderline personality disorder, you can treat the bipolar, but if you don't treat the borderline, they're not going to function better in life. If you treat the borderline first, then the bipolar condition and the more specific treatment for that has a chance of getting some traction. So the point I'm trying to make is that personality disorders have to do with the quality of a person's experience and their ability to deal with the challenges of life. And if somebody's impaired at that level, you're not going to treat them symptomatically with very much success, and research has shown that.
Well, it's interesting. I think about my own training in residency in personality disorders and how we've actually moved from, if you will, a trait-based, if you will, way of conceptualizing personality disorders to more of a dimensional way of thinking about personality disorders. And yes, I do, obviously, the axis system of Axis 1, Axis 2. And it's interesting that you brought up borderline personality disorder. One of the, and obviously I think of the work of Marshall Linehan and dialectical behavioral therapy, as well as many others in terms of conceptualizing borderline personality disorder, as well as Kernberg's work in terms of borderline organization of personality, and giving us a much more, if you will, nuanced look. But when I think of, for instance, that example of bipolar disorder and borderline personality disorder, one thing that I always reflect upon is that even when we talk about personality disorders, not too many people actually teach about what are like the two common, if you will, factors that we think about, most personality researchers think about. That's temperament and character. Normally when I ask a resident or if I ask a medical student about personality and I ask them, well, what do you think what are the two main, if you will, ways in which we define personality or start to think about them? And they're like, I don't know. And I think that gets at your, maybe one of your points that personality disorders just really have not, they certainly are becoming much more understood, but again, they it's taken us a while to really start to conceptualize treatments that are evidence-based, such as dialectical behavioral therapy and things of that nature, that really make a direct impact on personality disorders. Please.
Well, I'd like to follow up on what you said about the traits and the character. And for a long time in the DSM system, since personality disorders were introduced, I think in the DSM-3 in 1980, or at least that's when borderline personality disorder was introduced, the definition of these disorders has been more trait-based, which describes what you see but doesn't get at what the root of it is. So in the DSM-5, in the alternative model, in section 3 of the DSM-5, you have a conceptualization that's new within the DSM system, but it harks back to, you referenced Kernberg, and starting in the 70s, he described something called borderline personality organization. Now, what's really interesting is that research coming out of places like the Menninger Foundation in Texas supports that decades-old concept of personality disorders in general having what's called a G, or a general factor. And what is that general factor? It's difficulty in the appreciation of having a solid sense of self, being goal-directed, and really knowing who you are. So the new conceptualization is dimensional, especially in terms of this self-concept, how solid is one's sense of self, or how diffuse and vague and unfocused is it. So I think that's the concept that is sort of organizing our thinking right now. And in terms of the treatment options, dialectical behavioral therapy is very good for targeting the symptoms. But in my experience, and I have to acknowledge I come from a different tradition of object relations theory, which does focus on the experience of self, we have, a lot of people are treated with DBT and they do fine, and that's wonderful. But some people come to us offering this more psychodynamic approach, saying, I can control my behaviors now, but I'm not feeling a sense of satisfaction from life. And in particular, I just can't manage intimate relationships. So that's where I think this dimensional model comes in. You have to really develop a fuller, broader, and more both complex and satisfactory sense of self if you're going to negotiate your way through life with the simple satisfactions that every individual has a right to. Satisfaction in terms of gratification about who you are, what you achieve in life, and what you get from your close relations with others.
Okay. When I think about this, and with my experience in terms of working with patients with borderline personality disorder, there can be a tendency, I think, sometimes for younger clinicians to either maybe pick one therapeutic modality over the other, whether it's psychodynamic, psychoanalytic, CBT, or DBT. My experience has been that what you start out with frequently is not what you end up with. So, for instance, you may start with DBT, but as you are, which I agree with, what you're getting at is that once you have actually targeted and treated, if you will, very significant problematic behaviors, once you've introduced skill sets, once you've introduced mindfulness, now you've set the stage, if you will, for another form of psychotherapy, whether that's a psychoanalytic or a psychodynamic psychotherapy, in which you can further, if you will, think about this sense of self and how the person is experiencing their life. But I think one of the biggest things is, before you get there, or before you can do that, you have to make sure the person's sense of self or who they are isn't fragmenting. So I really feel as though the dimensional model, as well as the focus on the general and the sense of self, this can potentially allow us to, I already think we could, but combine multiple modalities in regards to working with our patients with personality disorder. And actually, some of my fellow colleagues, with borderline personality disorder, when you're treating with DBT, you would frequently reach, I can't speak for others, you'd reach a point in the treatment where you would say, I need something else, or I need a trauma-informed treatment, or I need to go to another level. And when you talk, that's what resonates with me.
Yeah, I couldn't agree with you more. And in an ideal world, we would offer the range of services to these patients, in a world where reimbursement wasn't so hard to come by. We've often thought about and written about a sequence of treatments which starts with the more CBT-oriented DBT type and then goes into the more exploratory psychodynamic type. Some individuals are lucky enough to have that, but since reimbursement is so lacking for so many mental health conditions, one of the missions that I have and the people I work with share is to try and make sure we can emphasize to our legislators, to our insurance companies, to the public in general, what a severe public health problem serious personality disorders cause, because they have an inordinate percentage of outpatient visits to clinics. Inpatients, a very large percentage of inpatients have personality disorders, and yet it's not given the same kind of resources. If you look at the NIMH funding for research, there's a lot of funding for research for schizophrenia. There's a lot of funding for research for bipolar, for autism. I'm not saying these things don't deserve our attention. There's a minuscule amount of funding for personality disorders, and yet these disorders are costing society and the system huge amounts of money. So that I wanted to say about the different modalities. I agree with you about a sequence. Most people don't have the funding for that. Let me just say something a little bit more, though, about the modalities themselves, because there you get into considerations of variations within personality disorders. We started out with the general topic of personality disorders. We began to focus on borderline. That makes perfect sense. Research has shown that what's wrong in the borderline personality seems to be at the base of all severe personality disorders. It has to do with that fragmentation you mentioned. This actually brings it into contact with neurobiology, because we know from brain studies that the centers for positive pleasurable affect and the centers for negative painful affect are different parts of the brain. You need to connect them through cognitive cerebral functioning. Cortical functioning. So in some individuals, they don't bridge the barrier between negative affects and positive affects so that they can blend the two into a rich appreciation of what life is all about. That's what we call splitting. You know, one day everything's fine, the next day everything's horrible. One day you're the person's best friend, something goes wrong, perhaps a minor event, and you become their worst enemy. So that's the fragmentation that you so correctly named, and that's what we try to help people get beyond, to develop an integrated self. Now, I just wanted to say a word about narcissistic personality disorder for two reasons. In the studies that my colleague Carla Sharp did down at Menninger in Houston, even though most of the personality disorders sorted out around this general factor that looks at its core like BPD, borderline personality disorder, narcissistic personality disorder has some separate characteristics. And what's interesting about narcissistic personality disorder is that that fragmentation of the self that you mentioned seems like it's not there, and yet it is. What happens in narcissistic personality disorder is that an individual develops a self-narrative that seems coherent, but doesn't correspond that well to the reality around them. Simple example, a patient was sent to me by her father who was very concerned about her. 4 years out of college, she wasn't doing anything with her life. She was kind of floating around, totally funded by him. And in the assessment interview, I kind of tactfully said to her, you know, most people, you know, in their mid-20s, a few years out of college, think about it at some point, having a career, you know, supporting themselves. And she looked at me like I was an idiot and said, well, yeah, of course I've thought about that. I've decided when I want to work, I'm going to be head of a major movie studio in Hollywood. It wasn't reality-based, but it kept her together. This idea, this narrative was grandiose, not realistically, like I say, it doesn't have a basis in reality, but it kept her from being distressed about all the unintegrated parts of herself. It didn't help her adapt, but it helped her move forward. Now, adaptation is also crucial because one of the simplest and yet most valid definitions I know of mental health is the ability to successfully adapt to the different circumstances in which you find yourself in life. And people with narcissism, they kind of soothe their own inner suffering by developing this grandiose narrative that doesn't really hold water. They can't get close to people because you can't find a lot of people who listen to an unrealistic narrative and say that sounds cool, and not question it. So we have a whole challenge with our narcissistic patients where if you challenge their narcissistic narrative, they either get enraged at you or they fall apart into just sort of desolation because you've taken away what holds them together. So the narcissistic patient, you need to sort of respect a fine line between helping them see beyond a self-image and a self-narrative that just doesn't correspond to reality, but not challenging it so quickly that they fall into a state of total disarray. I don't know if that's clear, but it is a different treatment challenge in certain ways from borderline personality, where you have the fragmentation and the internal disorder right up front. With narcissism, you have to deconstruct this false narcissistic narrative to get to the inner fragmentation and chaos, and then you can begin to work from there.
Okay. Yes, that actually does make sense. And I think about, I'm going to borrow a little bit from cognitive behavioral literature and go to a place where I think links some of these things. But I think about symptoms and behavior on one level. Then I think about beliefs. But then where I think that psychoanalytic and psychodynamic psychiatry start to blur and blend with CBT type modalities is schema. Like once you get into schema, like deep core beliefs in terms of interpretations of who you are, how you interpret or perceive life, this is where this, if you will, going back to what you said, Dr. Yeomans, really having a bit more of a nuanced understanding of how we conceptualize self, how we conceptualize adaptation. Because if you just take strictly a symptom approach, you could dislodge something that is it may be not completely adaptive for this patient in the moment, but to completely dislodge it without doing the work and really appreciating it can cause undue harm. So that makes sense to me in regards to what it is you said.
Can I give you two examples?
Please.
Because what you call schema, I prefer to call an object relations dyad, because it's an internal representation of the self in relation to another, connected by a strong affect or emotion. And these images of self and other are internalized in the course of early development, and sometimes they take on more complex and realistic characteristics. But for various reasons, in some individuals, these representations of self and other are fixed, rigid, and they don't correspond so well to the complexity of reality around you. So here's the two examples. My first patient who I ever treated right out of residency in psychotherapy was a very angry mix of borderline and narcissistic traits, and he sort of had a chip on his shoulder against everybody. He'd come into sessions and, as narcissistic patients tend to do, devalue me and point out everything that I did that was wrong. But you have to work with that. But in one session, as we were a couple of months into the therapy, he told me a very sad story about something that happened to him as a child, and it actually brought tears to my eyes, which of course was not volitional on my part, but it happens once in a while. So he looked at me and he said, "You have tears in your eyes." I said, "Yes." And he scrutinized me. He looked really hard at me, and then he said, "You're mocking me." And you see, that's the key to his pathology. Most people would see the other person's tears as a sign of empathy and being on their side. His internal representation of the other was so negative, he couldn't imagine somebody being compassionate, caring about him. And if you have that internal representation that is imposed on the interactions you have with others on a daily basis, what are you going to do? You're going to become depressed because nothing is ever positive in your life. You can't ever get close to anybody. So that's what I'm talking about when I talk about the internal representations that overwhelm an accurate reading of what you're actually going through in your life on a day-to-day basis. There was another example, but here's the other example. This happens all the time. People are treated for chronic depressions. They don't respond to medication. They're considered treatment-resistant depressive patients. you have to look at the personality structure. What are those internal representations of self and other? One of these patients started therapy fresh out of a hospitalization for a suicide attempt, and you could give him any medication under the sun. It just didn't change things. What happened in therapy was that it became clear that whatever I said, a little bit like the earlier patient I referred to, he experienced me as criticizing him, looking at him judgmentally, never having any kind of a positive response, even though that wasn't an accurate reading of what was going on. So when we could help him see how he was kind of filling in between the lines with a consistently negative reading of what was coming to him from others, he could begin to modify what you call the schema that was just condemned him to a depressed life because it didn't allow for any positive interactions with others. That's the level one has to get to if the symptomatic treatment in and of itself doesn't solve the problem.
Well, Dr. Yeomans, as you're speaking, I think about psychodynamic as well as psychoanalytic psychotherapy and the level that clinicians coming out have training in that, or the ability to actually go to that level with patients. We've gone through a lot of different, if you will, phases or movements in mental health, whether it was psychoanalytic psychiatry, whether it was psychopharmacology, whether it's the neuroimaging, genetics, et cetera, other, and I'm sure there will be more. But when I think about what you're getting at in terms of a clinician's ability to go to that deep level with a patient, I'm curious how, in terms of the training, because even when you go through residency, this takes years of collaboration with patients, practice, instinct to really have to hone down, to really be able to do this. How do you feel given the current pay structure and fee and timing and duration, how do you think clinicians can go about developing this now in this day and age? And I'm specifically talking about younger clinicians coming out now, not those who were probably trained in the psychoanalytic or psychodynamic schools.
Well, that's the question that preoccupies me all the time because for whatever reasons, working at this level is what I find the most satisfying and brings the most to the patients I see. I'm known as somebody who specializes in personality disorders, so these patients were referred to me and I have to work with them at this level. And I am always thinking about how can we make the training more efficient, how can we reduce it from the number of years it takes to, a more realistic length of time. And there are a couple of ways I think one can do that. Even though the work is based on psychoanalytic principles and concepts, which I find very valuable, there's something about the traditional practice of psychoanalysis that I find a little archaic. And one of the, some of my closest colleagues are analysts. I'm not fully analytically trained, but I'm very sympathetic to that model. But other fields in medicine are always looking for innovation.
Right.
There's something about the psychoanalytic orthodoxy that respects what has been done in a way that doesn't seem to invite innovation. And yet there's a whole group of us within that field who are saying, look, you can do research on this. We have done research on it. You can speed up the process. I'm not saying you can make it a short-term therapy, but there are certain ways. You don't respect this golden rule of analysis of free association without limit. Because what we've learned is that people can free associate literally for years and avoid the real issues. So you have to, first of all, when you begin the therapy, say, okay, how do we understand the problem and what are your goals? Because the idea that the goal should be just understanding without something concrete like to be able to hold a job and not get fired, to be able to commit to some kind of interest in life and not sort of give it up after a while, to get close to somebody and have the relationship work out. First of all, if you have agreed upon goals, then when you're meeting to try to do the deeper work of understanding, you're always saying, does this have a connection to why you're here? Are we drifting off in a direction that might be comfortable but sort of far away from what we should be thinking about? Let me give you a concrete example. I was treating a gentleman in his 70s, and he had been treated for depression for years in a more traditional therapy and with medication. I did an assessment. He seemed like a relatively high-functioning narcissistic personality disorder. So let me cut to the chase and the technique. So we, decided to start therapy. You have to always get a good assessment and know how you understand the patient, how you're going to proceed. And I said, I was giving him, I guess, the basic instruction about the psychoanalytic method. You come in and you say whatever's on your mind, but with the slightly different caveat, with some connection to the problems that brought you here. So he starts telling me in the first 2 or 3 sessions these really fascinating stories about having grown up in an exotic land far away from here. And I'm sitting there listening to him, but instead of just going on with the associations, I said, I'm a little confused here because you came here because you were depressed. By the way, I didn't say he was a man successful in his career, family, marriage, kids, grandchildren, money, everything one would want in life, except he was depressed and even had suicidal ideation. So, by the 3rd session where, I'm thinking, what relation do these stories about his childhood have to his goals in therapy? I said, I'm a little confused. If I didn't know you from our initial assessment, I wouldn't even know you had a problem you're working on. So what's going on here? So he could see, and this is getting back to the education problem, because if you can teach your residents and your trainees this, to not just listen, but see what the patient is doing with you, he said, I guess I'm just entertaining you. I said, well, that's fine, but you're spending a lot of money on these therapy sessions. Why would you come in and entertain me rather than work on the problems for which you're here? And we got to the core of narcissism, which is the narcissist, however successful they may be in life, don't think they have any core value. So he said, I guess I feel I have to entertain you because if I weren't entertaining you, you wouldn't have any interest in me. So I said, well, maybe that's the problem we should be thinking about. Your idea that unless proven otherwise, people have no interest in you, and you don't have a core value. Does that?
No, it makes sense. What I think about is we started talking about the changes in DSM-5 to a dimensional approach, as well as one that, if you will, places a bit more of an emphasis on general factors in terms of how a person appreciates, understands, and experiences the self, and particularly in regards to also in addition to adaptation. When I hear you talk, Dr. Yeomans, I think about, okay, we can attack the symptoms whether through medications or therapy. We can teach skills and very recognizing certain things in terms of distortions. But unless we're able to engage our patients in a deep exploratory sense of whom they are, we will inevitably be limited in our ability to help them understand and treat the key essential features that are causing them the problems in their ability to adapt. And we'll always be limited. And so the ability to do that in psychoanalytic psychotherapy and psychodynamic psychotherapy being, if you will, 2 therapies that can do so. Now, with that being said, I appreciate the fact that you said, but listen, we have to start to update a little bit. We have to actually roll a little bit with the time. So now I'm going to ask you another question. If there was, because you mentioned free association as an example, think out of the box. If there's one thing that you could do to, like, you'd want to see or just throw out there in terms of a revolution or a change in psychoanalytic psychotherapy from your years of practice, what would it be? Just radical.
Stop listening to the content of what the patient is telling you and read the interaction. What is he doing with you? What is he creating in terms of the relationship with you? How is he experiencing you on an implicit level? What is he asking of you on an implicit level? People waste too much time listening to endless stories and not seeing what the patient is doing with you, because what the patient is doing with you is what they're going to do with other people in their lives. And if they need therapy, something about what they're engaging other people in doing with them isn't satisfactory and isn't very adaptive.
Okay. Well, again, I think that I've always thought that psychoanalytic psychotherapy is, in my humble opinion, one of the most powerful forms of therapy known, period, because you are recreating the relationship, or you are seeing exactly what the patient is doing. But with that being said, you also have to be able to have the skills to look at and to see that. For, if I'm hearing you, don't just hear what the patient's saying, but interpret what is actually happening and how they're exhibiting, if you will, lack of adaptation in the moment. Because that to me, that's the key thing. Because it's like, if you can see it in a moment, again, it's like aha. And I think about that classic triangle of transference. I think about adaptive regression in service of the ego. It just takes. And I am not a psychoanalytic psychiatrist or by any way, shape, or form, but it takes a minute to get to it. But it also links us back to that idea of linking or stacking things and being able to refer out to your colleagues. So if you've reached a certain point with a patient, don't just stop there. Just say, you know what, we can get more. And maybe if you're not a psychoanalytic psychiatrist or a psychodynamic psychiatrist, or anyone who is willing to who has the ability to spend a great deal of time with the patient and understand their interpretations of their behavior in the moment, then refer out to one of your colleagues who is. And that's how we can continue to serve the patient. So Dr. Yeomans, please, you've really given us a very interesting take on personality and another look at how different modalities, including psychoanalytic psychotherapy, can be utilized to understand personality disorders as well as treat patients. What are some final thoughts that you want to leave with the listeners?
Well, there are a couple of thoughts. One is just about the direction of psychiatry.
Okay.
I'm getting on in my years. I still like to think I'm not too old, but when I remember back to my training, which was in the late 70s and 80s, there was just much more of a focus on the person. And I'm concerned about focus on symptom over the whole person. The 1990s was the decade of the brain, but now we have Tom Insel, the former head of the NIMH, who said that he oversaw $20 billion of biological research that he said didn't change the needle in terms of what the outcome of clinical care is. So I think while we need to focus on biology, we have lost our focus on the person as a whole. And I'm trying to put it most succinctly. We are biological beings, but what happens at the biological level is processed at a psychological level, the level at which we attribute meaning to what we're feeling and what we are perceiving. And that level of how the individual perceives meaning just has not been getting enough attention. So that's the first thing I would say. The second thing I would say is that, psychiatric conditions don't get the same funding in terms of research and reimbursement as other medical conditions. This is an injustice to all the people who are suffering from psychiatric conditions and a cost to society. So I think we have to look to the field of psychiatry to put the person back at the center and to look at our society as a whole in terms of the way it treats people with psychiatric illnesses, not to consider them second-class patients, but to consider them and treat them as seriously as a person with any other kind of medical condition.
Okay. Dr. Yeomans, thank you so very much for coming on the Psychcast today.
You're welcome. I found it very interesting, and if we can ever meet again and talk on other topics, I'd be happy to do so.
And that concludes this episode of the Psychcast. Remember, each episode has robust show notes available wherever notes are found in your app. The Psychcast is produced by Gina Henderson, executive editors Kathy Skarbeck and Mary Ellen Schneider. I am the voice of MD Edge Podcasts, Nick Andrews.